then level 2A, and level 5B. And this horizontal line at the inferior edge of the cricoid separates level 5B from 5A. So the central compartment include pretracheal, prelaryngeal, and paratracheal on either side, from the hyoid bone to the innominate artery. However, above the level of the upper pole of the thyroid gland, the hyoid bone, basically there are no lymph nodes there. So you don't have really to go up to the hyoid bone. And the supraintestinal lymph nodes are really not separated from the pretracheal. They are just located at the innominate artery. Now we have two neck dissections for the central. We have a therapeutic neck dissection. This is when you have a grossly pathological disease, clinical, CN1A. Elective neck dissection for occult disease, clinical N0, is controversial. There is no agreement on it. However, it can be considered if you have high-risk patient in the very old or the very young, and if you have large tumors above T4, and when there is aggressive histology, and when there is gross extrathyroidal extension, you might consider performing central compartment for N0 disease. Now, the neck dissection should be compartmental. There should not be what we call it berry picking, which was common practice in the 60s and the 70s, which means you remove only the grossly pathologic lymph node and you leave a microscopic small lymph nodes. We call it non-compartmental or berry picking, because this will put the patient at high risk of recurrence later on. And then reoperation or revision surgery is very risky with high complication rate. Now, the central compartment can be unilateral, which include prelaryngeal, pretracheal, and one paratracheal, either right or left, or can be bilateral. And if you have pathologic lymph nodes inferior to the innominate artery, especially in medullary thyroid carcinoma, then you have to prepare for a sternotomy to clear the lymph nodes. Lateral neck dissection is indicated for clinically positive disease. A minimum lateral neck dissection, it should be from level 2A to 5B. As we said, it's rare in 2B, posterior to the spinal accessory, and 5A above the spinal accessory in the posterior triangle. Unless there is contiguous disease. If you have pathological lymph node in level 2A, then you have to remove 2B. If you have pathological lymph node in 5B, then you have to remove 5A. And it should be comprehensive with the preservation of the spinal accessory nerve, the internal jugular vein, and the sternomastoid muscle. And same thing, there should not be berry picking. Now, complication you might encounter during neck dissection. General factors include patient comorbidities. However, tumor factors are related to location, extension, and invasiveness of the tumor. Complication rate increase when you have irradiated neck or when you have a previous surgery in the neck, reoperation. Now, in central neck dissection, the two major complications is recurrent laryngeal nerve injury and hypoparathyroidism. Recurrent nerve injury, Dr. Karimi did really a detailed lecture this morning about it. A hypoparathyroidism can be temporary or permanent. In the lateral neck, you may get nerve injury including spinal, accessory, marginal mandibular, sympathetic, hypoglossal, brachial, phrenic, and cutaneous nerves. Two important nerves are the spinal accessory and the marginal mandibular. The rest are very rarely get traumatized. You also can get chyle leak, vascular injury, which is very rare, seroma, and wound complications. It's important to do preoperative evaluation to avoid complication. Usually ultrasound is the primary initial evaluation for thyroid cancer, but you also need sometime contrast imaging, including CT scan, MRI, or PET scan. And now CT scan, you need it if you have extrathyroid extension to the larynx, the trachea, or esophagus. And when a patient has bulky nodal disease. And if you want to evaluate the retropharyngeal lymph node, central compartment lymph node, and mediastinal lymph node are difficult to evaluate with an ultrasound. This is an example of a patient with papillary thyroid carcinoma who has this one? Okay. Extensive nodal disease in the lateral neck and the central compartment reaching the innominate artery. Spinal accessory nerve injury occur about 27%. It can happen at level 2 or 5. It's easy really to find the nerve during surgery. And level 2, it's posterior or anterior to the internal jugular. And one landmark is the posterior belly of the digastric muscle. And you need also to identify the contribution of the cervical plexus to the spinal accessory nerve. It's a small branch. This is level 2 and 3. And you see the spinal accessory nerve on the left-hand side related to the internal jugular, the digastric muscle. And this is after clearance of the lymph nodes. The bed of that said is the prevertebral muscle, the levator scapulae, and the splenius capitis. Now, when you work there, try to avoid using electrocautery very close to the nerve, and identify the vein, identify the nerve, and then do the dissection. In level 5, especially in thin individual, when you raise the skin flap on the posterior triangle, you have to be careful because the nerve may be just subcutaneous in a very superficial location. And to identify the nerve in the posterior triangle, the easiest way is to do dissection along the anterior border of the trapezius muscle while you will encounter the nerve with a small blood vessel that accompany the nerve. With gentle dissection, avoiding traction, and electrocautery heat, you should be able to preserve the nerve. It's also important to identify the branching of the nerve, which may happen before the nerve enters the trapezius muscle. This is how a completed lateral neck dissection should look like. On the left side, you can see the cutaneous branches preserved, the great auricular, the lesser occipital, and you see the spinal accessory at the far left. And at the upper edge of the internal jugular vein, you see a small branch. That's the cervical plexus contribution to the spinal accessory nerve. And here, after retraction of the muscle, you can see the brachial plexus and the phrenic nerve on the anterior scalene muscle. A hypoglossal nerve rarely get injured, and it's very easy to identify. First, identify the digastric muscle. It's just below the posterior belly, and it's covered by the muscle fibers of the stylohyoid muscle and translateral carotid artery. Brachial plexus and phrenic nerve are really rare to injure, and they are easily identified in the posterior triangle. They are located deep to the omohyoid and transverse cervical vessels. And here you can see phrenic nerve on the anterior scalene muscle and the brachial plexus. And it's also important to identify the phrenic nerve before removing level 4 lymph nodes. When you retract that fatty lymphatic tissue, the phrenic nerve may get pulled with you up. So if you want to clamp and cut, you may end up cutting the phrenic nerve. So first identify it from C4, and then push it down, and then remove that tissue. Marginal mandibular, Usually it runs about 2 centimeters below the angle of the mandible. Just make an incision at the lower border of the submandibular gland, divide the facial artery, retract both of them superiorly, identify the digastric, and that's it. You have preserved the marginal mandibular.
2 minutes. 2 minutes.
Thoracic duct injury, up to 4%. It's a very serious injury. The thoracic duct usually is behind the internal jugular vein and the common carotid artery in the lower neck. And it got inserted in different locations, but most of the time it's at the junction of the subclavian with the internal jugular. And there are multiple lymphatic branches. One good policy is to separate the lymphatic tissue in the lower neck laterally and ligate about half of an inch of that lymphatic tissue. You have to clamp it and ligate it before dividing it. And in this way, you secure that you have ligated all the lymphatic branches. There is also a lymph node posterior to the interjugular vein at that location. It's a hidden lymph node, so you need to remove it. Otherwise, you will end up with recurrent disease in the future. Now, I always perform Valsalva maneuver. This is a completed neck dissection. And here at the lower end of the jugular vein is where the thoracic duct has been ligated. And so the lymphatic tissue, lateral, about an inch of it, clamp it and ligate it. And that way you can prevent a chyle leak. Perform Valsalva maneuver. If you see a leak, suture it with non-absorbable suture. If it didn't work, do a transfixion. Get a piece of muscle or fat and ligate it. You can also use, some surgeon report using like fibrin glue. But it's usually, you can easily close it with like 6-0 a Prolene suture and a piece of muscle.
1 minute.
1 minute? 1 minute. Recurrent laryngeal nerve, Dr. Karimi, he really did a good lecture, so I'm not going to go into details, but it's important to identify branching. This is a completed central neck dissection. You can see both recurrent nerves, and nominate and carotid artery. And the use of intraoperative nerve monitoring is helpful, especially in reoperation, in revision cases. In reoperation, one of the safest techniques is to start lateral to medial. So identify the common carotid artery and start dissecting medially with the use of a nerve monitor. Then you identify the nerve. And always work in a virgin area, an area that has not been, this previous surgeon has not gone into it, where you can identify the nerve easier than if you go into a scar area. And it's also important in the right side central compartment, there are a group of lymph nodes that are located posterior to the recurrent laryngeal nerve and the inferior artery. And it's important to dissect them and remove them. Otherwise, there will be a site of recurrent disease, which is really very hard to remove. In this gap, if you see this gap, there was a big lymph node there. This is the recurrent laryngeal nerve. This is just the branching of the facial nerve. Hypoparathyroidism, temporary is very common. Just 1 minute. Permanent is about 15%. It's important to preserve the blood supply by ligating the vessels close to the capsule of the thyroid. Now, it's easy to preserve the superior. It's very difficult to preserve the inferior parathyroid in central compartment neck dissection. So the safest way is to, this is a superior parathyroid gland. You sever the vessels close to the capsule. And the inferior parathyroid, I usually implant them. You can implant at least one. If you're not sure of the vascularity of the parathyroid gland, remove it, the inferior ones, and implant them. At least you can secure that the patient will not have a permanent hypoparathyroidism. It will function in a couple of months, start functioning. And thank you.